Thank you very much indeed for inviting me to come and take part in the AASD 2021. And today I'm going to discuss with you renal protection diabetes. I will cover these subheadings: the definition of diabetic kidney disease, early detection, and the therapeutic interventions available to prevent the development of diabetic kidney disease for primary prevention, i.e. in those patients who do not have the condition, and secondary prevention for those patients that have developed diabetic kidney disease, and we need to put in therapeutic interventions to reduce progression. What we know so far is that there's more than 4% of people with diabetes that will develop diabetic kidney disease. Diabetic kidney disease carries a very high risk for cardiovascular events and premature death. And importantly, diabetic kidney disease is actually preventable. The Kidney Disease Improvement Global Outcomes Group defined chronic kidney disease as abnormalities of the kidney structure and function present for at least 3 months in the patient. And they also classified a CKD from stages G1 to G5, depending on the glomerular filtration rate and the presence of proteinuria in the urine, i.e. albuminuria, A1 to A3, depending on the level. So G1 is a glomerular filtration rate of 90 or more, G2, 6 to 9, G3A, 45 to 54, sorry, 45 to 58, G3B, 30 to 44, G4, 15 to 29, and G5, less than 15 mils per minute. And normal albuminuria is levels below 30 milligrams per gram, and severe albuminuria is more than 100 milligrams per gram. So those patients that fall in the gray zone means that they have a good prognosis for renal preservation, and the ones that are in the yellow or amber or red, it means they're chronic disease is actually at a worse stage. So focusing early is important to prevent the progression from green zone to the red zone. And so how do we do that? The early studies published in the late 90s and the 2000s showed that the renin-angiotensin-aldosterone system inhibition had renal outcomes that were beneficial to patients. And this is data from 5 studies. The Renal study using losartan showed a composite endpoint reduction of redoubling of serum creatinine, end-stage kidney disease, and progression to death, risk reduction of 43.5%. Irbesartan, they achieved a risk reduction of 32.6%. Micro-hop using ramipril, 6.5% nephropathy and 15.3% cardiovascular disease or death. And captopril, which was the AASD, showed a risk reduction of 13.1% and ramipril of 31.1%. Following these publications, we have seen a huge number of studies come out since 2005, and some of these are already ongoing. And these are mainly focusing on glycemic control, but we have seen a lot of benefit also in the reduction of cardiovascular risk in these agents. And these are the SGLT2 inhibitors, GLP receptor antagonists, and DPP4 studies that some of these you've already heard about, and some of those you will be hearing about within the comments. In summary, we see that the SGLT2 inhibitor benefit on reduction of CKD progression has been shown in the studies shown on the left here, stages 1 to 2 CKD and stages 3 to 5 with the studies on the scale. And you can see that actually the hazard ratio reduction was pretty much significant in those patients that were given the SGLT2 inhibitors. Similarly, the GLP-1 receptor antagonist achieved hazard ratio reduction, and in these 7 studies, there was a reduction in all-cause mortality, hospital admissions for heart failure, and composite kidney outcomes, including macrobinuria. So where do they act on the glomerulus? And you can see that on the left here are the SGLT2 inhibitors. They actually increase the afferent tone. Doing so, they reduce intraglomerular pressure. On the right-hand side are the angiotensin-2 receptor antagonists, and they reduce afferent tone, and as such that causes glomerular pressure reduction. Initially, both groups, when you start treatment, you will see a fall in eGFR that tends to stabilize, and then you get a reduction in proteinuria, which suggests already that there is some renal protection. That translates into reduction in proteinuria, a fall in the rate of decline in glomerular filtration rate over time. The main strategy for renal protection, one, of course, is make sure there is good cardiovascular health for the patient, lifestyle modifications, and then you control to target glucose, blood pressure, lipids, make sure the patient is trying very hard to lose weight and stop smoking. And primary prevention relates to those patients who haven't had renal damage yet or haven't had a cardiovascular event. Secondary prevention relates to risk factor management in those patients that have already developed chronic kidney disease to reduce progression. So overall, a multifactorial approach is in the strategy for prevention. And here's a study published in 2021 that I mentioned previously. And in this study, they separated the groups into 2. One group had a target rate of HbA1c of 6.2% or less, blood pressure of 1.75, cholesterol level below 80 milligrams per deciliter. And in the conventional HbA1c of 6.9%, blood pressure under 130/8, and cholesterol under 120 milligrams deciliter. 2,540 patients were recruited and followed up over 5 years. Overall, kidney events occurred less in the intensive treated patients compared to the conventional. They mentioned that in patients with type 2 diabetes, multifactorial intervention and glycemic control reduces onset of nephropathy, whereas blood pressure suppresses progression of eGFR decline. And this is just another way to show the same study. As you can see, duration over time, there was a separation of the graphs showing a benefit with the intensive therapy compared to conventional therapy. And the graphs actually separated around about 3 years study. So the guideline for diabetic kidney disease, there's the American Hypertension Association guidelines that came out 2018, that blood pressure, hypertension is defined as blood pressure over 130/80, and then to get to 130/80 less. And stage 1 is 130 to 139, or 80/89. And stage 2 hypertension, or 140/90. Of course, you have to do lifestyle modification, as I mentioned earlier, but you can see weight loss. You may achieve a reduction of blood pressure of 5 millimeters of mercury and exercise. And in terms of glycemic control, we've mentioned physical activity, nutrition, weight loss for lifestyle modification. We can use metformin for patients with eGFR above 45. Below 45, we have to reduce the dose and stop metformin below 30 mils per minute. Metformin is contraindicated for dialysis patients. It's GLT2 inhibitors. We can treat patients up to eGFR of 30 mils per minute. After that, if it goes below that, of course, you should not use these agents. And then you can add on GLP-1 receptor antagonists if glycemic control is not adequate. And again, DPP-4 inhibitors, and then you can go on to something needed and insulin. Lastly, I just wanted to share with you the role of mineralocorticoid receptor antagonists. And this is a study published in 2019 in American Journal of Nephrology, the Fidelio PKD trial. They enrolled 13,911 patients and randomized them into two groups. One group had placebo, the other group had cenerenone, 10 to 20 milligrams per day, followed up over 2.6 years. You can see the characteristics of patients were similar in both groups for age, sex, race, duration of diabetes, controlled blood pressure, and body mass index. And then comorbidities again were similar in both groups. And you can see here the study that primary outcome event occurred in 17.8% of the cenerenone group compared to 21.1% in the placebo group. And again, you can see on the right-hand side shown the graph separated around about 18 months, showing benefits in the patients that had cenerenone compared to placebo. So in conclusion, ladies and gentlemen, diabetes is the most common cause of end-stage kidney disease and is a high-risk factor for cardiovascular disease and for death. Like glycemic control and cardiovascular risk factor control significantly reduces the development and progression of diabetic kidney disease. Lifestyle modification alone has little impact, but should be implemented first. And careful selection of the pharmacological events, proven record to reduce risk, are key in the preservation of renal function, not only for controlled blood pressure, but also for controlling intraglomerular hemodynamics to preserve renal function over time. Many thanks for your attention.
Thank you, Professor Kumwenda. It's a great pleasure to be with us here virtually, but we hope to be on the next year live with us. Professor Kumwenda is almost always our guest in the last 5 years here in Egypt with our conference. His interest about the kidney and diabetes. I would like to ask first, still you like football or not?
Yes, yeah? I'm still a great supporter for Liverpool, yeah. So and yes, thank you.
And you know Mo Salah?
Mo Salah is a legend. I mean, he is just the best football player at the moment in the world. He's great.
I would like to ask, what is about your opinion about the use of SGLT2 in patients with urinary albumin diabetes ratio, urinary albumin creatinine ratio. As regards the treatment, the use of SGLT2, is it decrease it or not? Is it indicated in type 2 only or in type 2 and some nephrologists prefer to give it with type 1 only? What's your opinion?
So definitely type 2 diabetes. The evidence is very good, and they're efficacious for reducing proteinuria and protecting the kidneys by reducing interglomerular pressure. That evidence is very good, and all these, some of these agents are already licensed for the use in type 2 diabetes, above and beyond ACE inhibition with angiotensin II receptor antagonists. So in addition to that, in addition to other hypoglycemic agents, these SGLT2 have been shown to reduce proteinuria, reduce the risk of diabetic kidney disease, and reduce progression of diabetic kidney disease, definitely in type 2. There are some studies that have been done in the use of SGLT2 in type 1 diabetes. The only problem with that group of patients is the risk of diabetic ketoacidosis. So at the moment, there is a lot of caution that we should be aware that there can be of some risk in type 1 diabetes. Certainly not for glycemic control. I don't think I would be very keen to recommend for glycemic.
What about your opinion about
damage?
about the use of GLP-1 in patients with diabetic kidney disease as regard the function and microalbuminuria? In the last meeting, you asked me about if you have, I have a trial with the GLP-1 and what is its effect on, you remember that, and what is effect on the kidney function. And I asked, it was very good with us. What's your opinion?
Yes, I recall our discussion. Yes, certainly. Again, the meta-analysis I've shown in the talk has shown that reduction in cardiovascular events, i.e. cardiovascular risk, hospitalization due to heart failure, and also positive kidney outcomes. So the GLP-1's antagonists have also been shown to be of benefit. So in the algorithm for treatment for type 2 diabetes, it does include addition of SGLT2 or a GLP-1 antagonist if the glycemic control is still poor.
Thank you. Any question? No? Thank you very much.
Thank you very much, Professor. It's been a pleasure to be with you.